Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people living in more than 90 countries around the world with the news that people affected by MS need to know. I'm also a non-scientist member of the International Progressive MS Alliance Scientific Steering Committee. I'm a district activist leader for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm thrilled to be with you today. I see that people are continuing to join our webcast, so let's give them just another few seconds and then we'll get started. Thank you to all of you who are joining us on GoToWebinar, Facebook Live, and YouTube Live. The MS Society's Ask an MS Expert webcast is designed to connect you with MS experts who are ready to answer your questions on the topics that impact people affected by MS every day. So as I chat with our experts today, please feel free to post your questions on Facebook and YouTube, or type them into the question box if you're joining us on GoToWebinar. We'll try to answer as many of your questions as we can during the Q&A portion of today's program. Pain is a common symptom in MS, and it's one of those symptoms that can keep you from fully engaging in life and doing the things that you enjoy. Pain is also a very personal experience, and unfortunately, it's one of those invisible symptoms, one that you can feel but others can't see. But there are things you can do to improve the way you feel and help minimize the impact pain can have on your life. Today, we're talking about pain with Dr. Dawn Ehde, a clinical psychologist and professor of rehabilitation medicine at University of Washington Medicine. Dr. Ehde has an endowed professorship in multiple sclerosis research, and Dr. Ehde and her group at UW have conducted several studies on pain in MS. The results of their research have been published in scientific journals, and they've contributed to the development of educational programs on pain for the National MS Society. We're also talking with Dr. Heidi Maloni, a nurse practitioner and the National Clinical Nursing Director for the Multiple Sclerosis Center of Excellence East at the Veterans Affairs Medical Center. Dr. Maloni heads up research programs to further the understanding of MS and its impact on veterans while aiding in the development of treatments to manage the disease and its symptoms. Well, I want to thank you both for being with us today. And
great to be here.
Thank you, Dr. Ehde, and we should be seeing, there we are, Dr. Maloni, welcome.
Yeah, welcome, it's great to be here as well.
You know, pain is one of the most common symptoms of MS and one of the most challenging. Dr. Maloni, maybe you could start us off by explaining what is MS-related pain and what causes it?
Great question. You all know that MS is a disease of the brain and the spinal cord and the optic nerve or central nervous system, and that lesions in the central nervous system slow nerve conduction, causing symptoms. Now, one of those symptoms happens to be pain in about 50% of you who experience pain. So, for example, burning extremity pain or that sharp stabbing facial pain, or the pain of an MS hug that's tight around the rib cage. Those are caused by a lesion on the nerve. So people with MS experience muscle and bone pain as well. Calling on those back muscles to help pull the weight of heavy legs through your gait when you have some weakness, that's going to ultimately cause back pain. So MS pain comes from lesions in the central nervous system, distinct to MS, and it also because you have MS and living for a while with MS can cause pain in the musculoskeletal system.
We often remind everyone that MS is a complex disease that requires a comprehensive approach for optimal management. This means a person living with MS should be working with multiple healthcare providers from different disciplines, different specialties, to ensure that they're managing their health most effectively. Dr. Ehde, can you tell us about the role a psychologist plays in assessing and managing pain in MS?
Yeah, well, as you just heard Heidi describe, pain comes from damage in the central nervous system. Well, we also know from a wealth of scientific evidence, and including modern brain imaging techniques that many of you are familiar with, such as MRIs, that the brain plays a very active role in the processing of pain or how people experience pain. In fact, the brain is really in charge of how much pain we feel as humans and what that experience is like. And interestingly, we know that multiple regions of the brain are involved in pain processing. And in many of these are also areas that are involved in the processing of our thinking or our thoughts, our emotions, and our behaviors or what we do. And so the experience of pain then is influenced by the way we think, our emotions, and our actions. It's very interactive. Kind of like I like to tell people, it's like a volume on a stereo or a radio or a television. We know that some things turn down the pain volume, and other actions, thoughts, emotions, or medications, for example, can turn them down, and others can turn it up. That is, people can experience more pain or more pain impact based on even things like what they think and do. So I say that all which to say that it means that because pain is complex, it's processed in multiple areas, it also means there are multiple strategies that can help people manage their pain and reduce their pain. And many of these are actually psychological treatments that psychologists have been using, in fact, in pain care for more than 40 years. So psychologists play an important role in assessing how is pain impacting a person, what thoughts, emotions, or behaviors might be unintentionally turning up the pain volume, and what things might be done to decrease the pain volume or improve the experience of pain.
When we talk about MS requiring a comprehensive approach to care beyond psychologists, are there other healthcare professionals that might be involved in helping someone manage their pain?
Absolutely. Because pain is so multifaceted, I believe, especially when it's chronic, that really multiple players should be involved, and they all play important roles on the team. So these include, not only physicians, but also nurse practitioners, physical therapists, occupational therapists, massage therapists, and others. So for example, as Heidi mentioned, sometimes people have pain because they maybe move less or because a change is due to MS. And so sometimes a physical therapist can be really helpful in helping a person to move in better or different ways that can actually end up decreasing the pain.
Pain is subjective, meaning that only the person experiencing it can really tell how bad it is. We heard from Brenda, who's asking, how can we get our doctors to understand this weird pain we have, and more importantly, to take us seriously? Dr. Ehde, tell us, what questions do you ask your patients to assess their pain?
Yeah, well, of course, like most healthcare professionals, I do ask about pain severity. That's that 0 to 10 scale that many of you are familiar with, and it sometimes really doesn't capture what your experience with pain is like. I also spend, though, a lot of time asking about how pain impacts a person. So, for example, I ask, how is it affecting sleep? How is it affecting fatigue, mood, memory, other MS symptoms, and how is it affecting how a person functions, their relationships? What is pain keeping you from doing? What are you doing more of? What are you doing less of? Do you notice how stress affects your pain, if at all, or your sleep? And we know that for people with MS, pain is not the only symptom that they're dealing with. And so it's really important to see how these things influence and interact. And I like to also ask, how are people managing their pain? People are experts on their pain management, even if they're struggling with it to some degree. So I always like to say what's working, what isn't. And all of this information can really help us devise a treatment plan that may include the care not only from a psychologist such as myself, but other people on the team.
So circling back to Brenda's question, what can she do to best describe her pain, and how does she get her doctor to take her pain seriously?
Yeah, unfortunately, that's Something I still hear from people with MS is that their pain isn't being taken seriously by some of their providers, especially maybe providers outside the MS community. I recommend describing two things at least. I'd really talk with your provider about what pain is getting in the way of. You know, for example, your sleep or playing with your kids or work. I'd also tell your provider what your goal is. Like, why do you want your pain to be taken seriously and managed better? And have it not be just about decreasing your pain, although that's certainly very important, but also what do you want to get back to doing? What do you want to do that's healthy? This may help your provider really see how serious your pain is because it's really impacting you, and also help give them ideas on other ways to help you treat your pain and other goals to focus treatment on.
Dr. Maloni, I'd like to ask you the same questions. In other words, what questions do you ask your patients to assess their pain?
So I'm very interested in descriptions of pain and assessments because it leads me to know how best to treat the person, how they describe their pain. I like what Dr. Ehde said about, well, essentially she was saying putting pain in context for the doctor so that he knows how it really interferes or affects the rest of your life. And he recognizes how important it is to your total function. How is your sleep? You know, how are you able to have fun with your family? Do you hide in the bedroom because you're such a grouch, nobody likes you anymore? That's what pain can do. It can change who you are. So in the pain that's musculoskeletal or is it nerve pain, I want to assess that. And I want patients to tell me when they sometimes describe pain as having itching so bad and so intense that it's painful, or ants that are crawling all over their face, water running down their legs, ice cold water, burning in their legs and their feet, or burning spots on the legs, and usually that's in the thighs. And then I ask them, is your pain steady or does it come and go? Is it sharp? Is it shooting? Is it stabbing or dull or throbbing or aching? Kind of tell me, really, really describe it. So Dr. Ehde made some comments about she likes to have the doctor know, you know, when was the onset of that pain? When did it start? What is it like? And I would suggest to Brenda that she keep a record of this, kind of a diary. And she that with apps on the phone. And that would be my takeaway message for Brenda. I mean, tell the doctor in a diary form so that she can record when she's having this pain and she's most in tuned to the pain and to her sense of it. She can write it down. When did it start? How does describing it? What does she do to treat it? As Dr. Ehde said, it's very important to know how she treats it. And that will help the doctor understand best how to treat her pain, because dull, aching pain is treated very differently than sharp stabbing pain. You know, is the pain stimulated? Can it be evoked? Does it just happen out of the blue? Questions like that. So for Brenda, good descriptions of pain can help the doctor understand her pain.
Beyond the context that a patient might provide, are there any formal scales that you use, Dr. Maloni, in assessing pain?
Yeah, absolutely. You know, I'm not a huge fan of the visual analog scale. Dr. Ehde mentioned it. It's that scale 1 to 10 where you say, how bad is your pain? You know, 1 is no pain and 10 is the most intense pain you've ever felt. And, you know, a lot of people are willing to tell me that their pain is 14. Well, that tells me something. You know, it's not on the scale, is it? But it certainly tells me something about how they're not coping with that pain very well. And in some ways, that's sort of a wake-up call to me to sit down with a person and say, what parts of the team do we need to gather to help you manage your pain? So assessing pain is very important. I'm kind of getting off the topic here, but I use other formal scales. I like to use functional scales that talk about the interference of pain in a person's life, like Dr. Ehde said. And the visual analog scale, if I put someone on a treatment, whether it's medication or another kind of treatment, and they come back and tell me that their pain has been reduced by 2 numbers on that visual analog scale, I'm going to say, hey, that's huge. That really means that treatment made an effect. So how does pain affect their usual activities? I like that. I'm most interested in that. You know, how does it affect their sleep? Are they able to sleep better? Are they able to recreate better? Scales like that are functional scales. Those are scales I like to use.
You know, we've received what I consider two different versions of kind of the same question. Amy wrote in to say that she has lower back pain and feel like spasms, and she wants to know if that's part of MS. And Kevin says he gets frequent headaches, and he's wondering whether his headaches are related to his MS. Dr. Ehde, is the root cause of someone's pain, whether it's from MS or not, is that important to identify? And I guess as a follow-on to that, I'm curious as to how you explore the causes of pain with your patients. Are there specific tests or assessments that you use?
Yeah, that's a great question. That's one of those I want to say yes and no. I mean, yes, it's absolutely important, as Dr. Maloni described, to understand the root cause of pain, and often it's root causes because there's multiple things contributing. I will say though that it's not important in that sometimes I've had patients who say because their pain doesn't seem to be related directly to their MS, maybe they had a back pain problem before MS and it's gotten worse, and that sometimes they feel that that's discounted or ignored because it's not directly related to their MS. And I would say it's absolutely important whether or not it's coming from the MS, something else, or a combination, because we know that pain is super complex. And in fact, a recent study of over 800 people with MS done by colleagues, Dr. Anna Kratz and Dr. Tiffany Braley at the University of Michigan, found that about 41% had pain that we would classify as coming from damage in the central nervous system. 40% had pain what we would see as more related to like the musculoskeletal, like deconditioning, spasms, from sitting in a wheelchair with in poor posture for too long. And about 60% had pain that seemed to be damaged to the central or peripheral nervous systems. But interestingly, many people have both types of pain at some point in their course of MS. In terms of how we assess causes of pain, as a psychologist, I'm very interested in assessing how are people sleeping, how are they, how's their mood? Do they have a major depressive disorder or anxiety? How do they cope with pain? What are their thoughts in response to pain? And again, what have they tried? What's their stress level? How do others in their environment respond to them when they talk about their pain or aren't able to do things because of pain? All of those can give me information that can help me, work with a team to come up with a treatment plan.
Dr. Maloni, are there tests that you use to ensure that the pain your patient is describing to you actually comes from their MS?
Yes, absolutely. A good neuro exam is the basic test. A good sensory exam, understanding when you put the pinprick on the person's body, where it feels dull, where it feels sharp, where it feels excessively sharp. So a good neural exam, a good strength exam, a good balance exam, a good reflex exam helps understand where the pain, if the pain is really relegated to MS. And then, of course, imaging studies. The cause of pain really does matter. Painful spasms are treated very differently than stabbing trigeminal pain. Sorting out the burning pain that radiates around the hip and into the thighs, is that neuropathic MS pain, or could that be a lumbar disc that's protruding and causing that pain? So understanding that through a neuro exam and then maybe imaging the lumbar spine to see if, maybe there's a disc issue, maybe there's a facet issue, maybe there's something architecturally degenerative joint disease that's the cause of that pain. So that's important. So, and even new tingling in the arms, could that be cervical pain or neck arthritis in the neck? And there can be a lot of joint pain that's associated with multiple sclerosis as well. And that may or may not be a part of the nerve causing that joint pain. It may be that there's another autoimmune issue going on in the joint, and a referral to the team of rheumatologists could be very, very important to sort that out. And we've seen comorbid autoimmune diseases on top of multiple sclerosis as well. So recognizing the source of pain is hugely important, and then getting the imaging studies and the studies that can back that up.
We heard from Delman, who wants to know what can be done for chronic nerve pain. He says that none of the medications he's tried have really worked for him. Dr. Maloni, How effective are the medications that are commonly used to treat MS pain?
They can be very effective, but it depends. It depends if you're using the right medication for the right type of pain. You can't give someone a blanket gabapentin and expect it to be effective for all types of pain. I mentioned a specific medication, an anti-epileptic medication, but I recommend a combination of strategies, and Dr. Ehde is really best to speak about this, but both medications and non-medications, because pain is complicated. And you need everything in your armamentarium to manage that pain. Non-medication strategies that Dr. Ehde has alluded to, and on top of that, if you can stand to have your extremities touched, then using things like heat or pressure or ice, cold, massage, those are good strategies too, along with medications. Medications for neuropathic pain include things that affect neurotransmitters and modulators of pain signals. So the classes of drugs that are commonly used are antidepressants, anti-epileptics, anti-inflammatory agents, anti-spasticity agents. And all of those are pulled from other disciplines because they're essentially affecting neurotransmitters that are causing pain in a person or able to modulate the pain experience. I often recommend, when I talk about medications, to choose 2 different drugs from different neurotransmitter blocks and use low doses of those drugs. So yeah, drugs can work. And sometimes we have to give drugs a chance. The person who takes a drug home and uses it for a day and says, well, that doesn't work, it's not giving it a good enough chance. So you got to use it for a little bit longer than a day. And you have to, and it's not just meds. I think meds are going along with some other things.
Well, Dr. Ehde, once you've explored how pain is impacting your patient's life, what are some of the interventions you suggest to help manage it?
Yeah, so I think really looking at the whole person. And so one of the common things a psychologist can do is to help to sort through and offer treatments and strategies for managing pain in the non-pharmacological arena. So for example, if in talking with someone we determine that they're depressed, we know that depression can make people's response to pain treatments less successful. We know that it just can increase pain. And so making sure that person has gets treatment for their depression or anxiety, which could be a whole variety of things, both therapy, counseling, as well as medications. However, that's just a small group of people who have pain. Many people I find aren't depressed, but still have pain in MS. And so it's teaching them things like stress management. Pain is a chronic stressor. If you're living with pain day in, day out, and it's getting in your way, that's like living with, a big bear, across the hall or some, chronic stress going on. And we know the body's not meant to be in fight or flight mode all the time, which is what happens with stress. And so helping people to learn stress management techniques to, recognize how they think about their pain or their stress, to learn ways to have to teach their thoughts to be more automatically helpful, to help people learn relaxation strategies, meditation strategies such as mindfulness meditation. We're doing a lot of work in that because people are finding it can be very helpful for pain. Also looking at sleep. So we have a variety of what we call cognitive behavioral strategies to help people learn ways to sleep better through their habits, their sleep habits, as well as kind of trying to address those automatic thoughts that can happen when you wake up in the middle of the night, you can't get back to sleep, and you think, oh, here I go again, I'm not going to sleep, I'm going to feel terrible tomorrow. How do you break that cycle of unhelpful thinking? Also, I think there's one other area I want to mention is just this whole area of physical activity. It's easy for us providers to say, hey, go be physically active. But when it hurts when you move, we have to get creative in teaching you ways to do that, especially as you're getting back into some physical activity. So physical activity we know is beneficial for pain in general, but psychologists can play a role in helping you set up, small, realistic goals to get you back to doing more things physically.
Listening to you talk about some of these interventions, I'm wondering, can someone or should someone use these sorts of interventions on their own, or do they need to be working with a professional?
People can absolutely learn these on their own. In fact, that's what I recommend. There's too few of us doing this kind of pain psychology work with people with MS. I mean, we're out there, but certainly I think it's best for people to first start just learning how to use these tools on their own. There's lots of different strategies, and especially now there's virtual classes on, for example, mindfulness meditation or stress management. There's workshops. All sorts of things that you can access free or at low cost. And people with MS can benefit whether or not the specific class or workshop, say, on mindfulness is designed just for people with MS. So I do want to point out one thing, though, about that. I was thinking, Dr. Maloni mentioned that you have to give things a try. When it's a medication, you can't just take it once. Well, same thing's true with these kinds of strategies. It's really important that you give them a shot for a while. So if you start doing, say, relaxation or mindfulness meditation, for example, you need to really keep going and keep giving them give them a try them for several weeks or a month, and track maybe in your diary that you're keeping about your pain. What are you noticing? Many of these things, it really does take practice and time for them to really kind of rewire your brain to respond differently to pain.
You know, Dr. Ehde, you just mentioned sticking with it, and I'm thinking of side effects. And there are side effects to both medications and to therapies that you're recommending, like exercise, because it hurts or it doesn't feel good at the beginning. So when you have pain, do your best to manage those side effects with your team. I mean, certainly with its medications, it's the good provider relationship that is important and be on top of it all the time. Hang in there. Trying a new drug and resisting the urge to quit is not helpful. So I like the idea of keeping that in a diary, like Dr. Ehde said, and getting over those side effects, seeing if you can get on top of it.
Well, if we're talking about managing pain, then we should also be talking about cannabis. Many of our viewers have submitted questions about using cannabis to manage their pain. So, Dr. Maloni, there's a lot of different terminology that's associated with this subject. Medical marijuana, cannabis, THC, CBD, I guess just to name a few. Are these all the same thing, or are they different?
They are all different. They're very distinct. So people seem to use marijuana as the overall discussion when they talk about cannabis, but it's actually the plant cannabis. It refers to the whole plant. That is the umbrella term for the medications that are under it, the subunits that are CBD and THC. So cannabis, as I said, refers to the whole plant. It's the organic products and compounds that are derived from the cannabis plant that are THC and CBD. So marijuana is a subtype of cannabis. Now, marijuana refers to the part of the cannabis plant that is high in THC or tetrahydrocannabinol. That's the psychoactive component of cannabis, the part of cannabis that gives the high. Hemp is a part of the cannabis plant, and it has very low levels of THC, and it has less than 0.3% of THC. And high levels of something called CBD or cannabidiol. Now that's the non-psychoactive component of cannabis, CBD. CBD has become a hot commodity. It's all over the internet. Most of my patients are telling me they're using it and they're getting it on the internet. Their pets are using it as well. I don't know why. I mean, maybe for anxiety or too much barking, but yeah, their pets are on CBD as well. So those are essentially the very different cannabis, THC, CBD. Now hemp, on the other hand, when you see it on the internet, really sometimes has very little CBD in it. So you have to be careful about labeling, and I'll get into that in a minute. But that's exactly the difference.
Well, let's get into it now, because we get a lot of questions around the use of CBD for MS pain.
Okay.
So what can you tell us? what can you tell us about the effectiveness of CBD for managing MS pain?
So that's a great question. You know, there have not been any studies of pure CBD in MS pain. There have been a good study, I think back in 2005, with a drug called Sativex or nabiximols that was a combination of THC and CBD, 1-to-1 ratio. The THC was 2.7 milligrams and the CBD was 2.5 milligrams. And I know you all are interested in doses. The total daily dose of the Sativex, it was an oral mucosal spray shown in a 600-person study that showed subjective effect on a person's pain, sleep, spasticity, so that it was used, but it was used in the Sativex. CBD has never been used by itself for MS pain. Now, there have been CBD studies in rats and mice that have shown an effect on pain, and there's been one CBD study in rheumatology for knee pain or arthritis in the knee that showed an effect of the CBD at that level. There are many limited studies. There's only been one pure CBD study with children who have epilepsy. Epidiolex is the FDA-approved drug, very pure form of CBD to manage epilepsy in kids with refractory, specific kinds of epilepsy. The most effective trials have been in the childhood epilepsy. And as I said, no trials in MS pain that I know of. Certainly the animal studies, but CBD has good anti-inflammatory effect. It has anticonvulsant effect, antioxidant effect. The World Health Organization has said that CBD has very little abuse potential and it's safe. So that is one of the good claims for CBD. It's not the non-psychoactive component of the cannabis plant. I said it's becoming ubiquitous. There are CBD oils. CBD can be smoked or vaped, and it can become in an oral form and topical. When it's taken by mouth, only about 6% is bioavailable to the person. So that's very little. Much more in the vape, but we want to discourage vaping because of the risk for lung disease. So I would definitely discourage any sort of vaping. But a very CBD and THC are very lipotrophic. What does that mean? That it harbors in fat cells, and it can have very long-lasting effects because of that. One of the better ways of administering CBD is in topical methods, through transdermal patches or through topical oils. Is one of the safest and probably the most effective for getting into the system.
Are there risks or concerns about using cannabis or cannabis components, I should say, to manage MS pain?
Yeah, so there are a couple. When we talk about CBD alone, and that's becoming the commodity that our patients want, there are a couple things to be aware of. Now, the side effects are minimal, and they're usually sleepiness. It's pretty well tolerated, but it could cause some sleepiness, some dizziness, some GI upset, some nausea. But most important, it can increase the liver enzymes. And the critical thing here that I want to tell you all is that, you might be on disease-modifying therapies that are also at risk for increasing liver enzymes. And your doctor needs to know that you're taking CBC, because if he sees an uptick in your liver enzymes, he's going to blame your drugs that he knows about. And if he doesn't know about CBD, he may be decreasing your other medications and inappropriately. So please have that conversation with your provider about using CBD oils or however you're using it, or THC, whatever you're doing, it's going to get an uptake in LFTs. There's also 100 interactions with other drugs. Your physician, and I know your eyes got bigger, John, and I wanted to be impressive with that. There are many interactions, and with CBD, not just THC, with CBD and other drugs, it lowers the effectiveness of cladribine, if anyone's on that specific disease modifying therapy. And it may limit the effect of some of the other medications you're on. So please have that conversation with your doctor. Liver toxicity, increased sedation. And then I might add, both THC and CBD need to be kept at low temperatures, and they need to be kept in the dark to have a full effect. When you go into a dispensary, where do you see your CBD? Yeah, it's in an apothecary jar that's clear so you can look inside and see it, right? That's exposing it to light. It's also sitting out, on the counter. You're also going into a dispensary and you're asking the unmedical person, the non-medical person there, what should I have? Should I have houndstooth? Should I have the stuff that helps with fatigue? And they have all these exceedingly exotic names attached to them. But those folks don't really know what they're selling. And they may be pushing the drug that's expired, or the drug, I'm doing the CBD or the THC that's actually expired. A couple of other cautions. When a manufacturer is producing THC or CBD, they're doing that through a process where they need to use toxins to bring the plant or the seeds out and get the product that you experience. So they may be using things that are cancer promoting when they're manufacturing it. The only pure, 99% pure CBD is Epidiolex, the drug that's used for seizures. So that is the only one. We don't know the CBD or the THC that you're getting. We can't guarantee that because it's not regulated. So I might suggest, and one of the take-home messages when we get to is that you look at the label, and if it says good practices have been used here, clinical good practices have been used, then you know that there's some consistency. Manufacturing practices have been used to get this drug to market. Now that you're going to find usually not an American made, but mostly drugs that are German made maybe, or CBD that's German made. But you want to look for those good practices label, and that might help you know that there's been some regulation of the CBD. CBD, if you're using it, you don't want to abruptly stop it. So this is the last caveat maybe. It's fairly safe, but it could cause seizures when you abruptly stop it. Because of how it works in the brain. CBD, you want to do slow titration off your CBD so that you're not at risk for causing seizures. The risk with THC, there's addiction. THC can be addictive. Yeah, you're going to say no, but yes, science has shown that THC can be addictive. There's a risk for worsening cognition with THC. There's studies have shown that folks using marijuana, high THC, and when they've been abstinent for a period of time and then retaken some cognitive tests, that they still showed 30% decrease in global cognitive ability because they've been constant users. Labeling accuracy is really important, making sure that what's on the label is what's in the jar, the amount of CBD. And when you're buying straight CBD, make sure that there's low levels of THC, because that also may not be accurate. You may be risking some psychoactive medications with that THC being added and unknowingly. So contaminants, solvents, and pesticides that are used to manufacture. Storage, how is it stored? Is it stored at 4 degrees centigrade in a cool environment? Is it stored in a dark container? Is the labeling accuracy accurate? And is the dispensary staff trained? Do they know what they're selling? Cannabis products have been shown in clinical trials, yes, to improve subjective MS spasticity and pain and improve sleep. Yes, these studies are done with standardized research grade preparations, studies, not what you're buying. And they're not preparations that are usually available in the cannabis dispensaries. That's the bulk of what I have to tell you.
Thank you. Some important information there. Dr. Ehde, I'd like to ask you the same question about risks or concerns about using cannabis to manage MS pain. As a psychologist, do you see side effects from cannabis that impact your patients?
Yeah, I think it's really, for me, it's really about finding the right balance. I mean, for some people, they find that, it may have some cognitive side effects, or, some increased sleepiness, but those side effects or concerns outweigh the fact that they're actually able to do more because their pain is relieved and they're functioning more. That's for some people. Other people, I find that it gets in the way of their lives. So you kind of have to look at it. Is their use helping them to become more functional and feel better, or is it going down that road of potentially becoming an addiction, or at least something that's used enough that it's getting in the way of their life? So I don't see it as good or bad, but rather trying to find out what makes the most sense. And unfortunately, we don't have sufficient science to guide us on some of these things, other than just the very few studies Dr. Maloni mentioned.
Speaking of studies, Dr. Ehde, you recently published results from a study you were involved in that examined the use and the impact of cannabis among people with MS. What did you learn through that study?
Yeah, this was a study done late last year, right before the pandemic hit. So I can't speak to what the results would be now, but we found that at that time, large study, over 800 people with MS, we found that 42% had used some form of cannabis in the last year. So it's very common. That was one of our take homes. People are using it. We also found that people reported that using it has a lot of benefits to them in terms of their symptom management, not just pain and sleep, but other MS symptoms. And I think what that study really highlighted for us, because it was a survey study, so it wasn't looking at the effectiveness, but just how's it being used and what do people with MS think about it? And I think it really highlights this discrepancy between how people in the community, in the MS community, are using cannabis and trying to understand how it affects them and what we actually know in clinical practice. And so for me, it just speaks to the need to have more research in this area.
Dr. Maloni, I'm sure you get lots of questions on cannabis from your patients. How do you interpret the results of studies like the one Dr. Ehde just completed, as well as others? And how do you talk about these study results with your patients?
So I would like to echo what Dr. Ehde just said, that we've come to a place in MS pain where cannabis has a place. And when patients come to me and talk about cannabis, I welcome that, because I want to know. I don't want this to be a secret. I don't want them to hide it from me, because of things like the increase in liver function and things that might interfere with other drugs. But how do I interpret the studies to them? I really am concerned about cognition. Patients are more concerned with sleep and pain, of course, and I like what Dr. Ehde said about a balance. I like to listen to what the patient has to say. I want to hear how marijuana or CBD or THC is working in their life. I want to present one or two studies on the effects of cognition. I might even give them the papers. I might even actually go over it and give them some of the results. I also want to point out that the studies that were done in pain were acknowledged for their subjective ability to affect pain, and not necessarily and spasticity, I might add, and not nearly the objective. So when I look at spasticity, I move the arm and the leg, and I use an Ashworth scale, a scale to measure spasticity. But that Ashworth scale was a negative finding in the studies of cannabis, the THC and 1-to-1 CBD. But the patients all said it did help. And we listened to you. We listened to the patients. And that Sativex was approved. In 27 countries, it's approved. It's being looked at now at the... So I like the idea of balance. And if I find a patient coming to me and saying, without telling me that they're on cannabis, it's suddenly that they had a change in their cognition. And we go to the neuropsychologist and we find out they do have some change in cognition. Neuropsychologists are very in depth when they do their assessments, and they find out things. And when they discover that the patient is new user of THC, they may put the two together and help the patient understand if they cut back a little bit, they might have better thinking. Or maybe reserve their CBD and THC for bedtime use. So that's kind of how I operate.
You know, I've heard you say this a couple of times in our conversation today, really underscoring the importance, we talk about it all the time, of making sure you have that conversation with your physician about all of the medications you're taking, including the non-prescription medications, because they do have consequences, they do have potential interactions, right?
That's right, John. Oh, yes, well, I would echo that.
Well, we've covered a lot of important information today, and I'm hoping that you'll each share the top 3 takeaways that you'd like our audience to keep in mind. Dr. Ehde, let's start with you.
Great. Well, so the first one I think is that I want people to know there are many, many resources for learning how to manage pain, such as mindfulness meditation and so forth. In fact, I want to point out one. We currently have a randomized clinical trial going on at the University of Washington that's funded by the MS Society. It's called the ADAPT study, and you'll find a link to it at the end of the presentation today. But this is a study comparing CBT or cognitive behavioral therapy to mindfulness meditation in persons with MS and pain, and we're doing it via Zoom virtual groups. So it's a treatment free to you if you have pain and have MS and want to learn some techniques for managing it. I recommend you check out our study. We'll be enrolling people now for just another about maybe 6 months. So please check that out. Also, there's other websites, including My MS Toolkit. The MS Society has lots of great information on pain. So there's resources. There's many ways to learn these. Second thing I want to point out is that, as I kind of hinted at before, you kind of have to take an experimental approach. So what might work for one person may not work for the others. Some people swear by, for example, mindfulness meditation in their pain management. Others say they just don't find it helpful. So I think, try out different things. Think of it as having a menu of options that you can pull from when you're having a pain flare-up or when you're in pain, or just as your daily part of your pain management. And I think it's also important to think about it as a daily plan. The more you practice, just like exercise or other things, the more you're going to rewire your brain to really dampen down those pain signals. And just a third point I want to point out is that if you are really struggling despite trying to do things on your own, your mood's really affected, your life's really affected, I really encourage you to talk to your provider and to consider seeking care from a psychologist or other mental health professional who knows something about MS and pain.
Thank you. And Dr. Maloni, what are your top 3 takeaways?
Well, pain is complex, and we've just discovered that during this hour, right? And it demands a serious and complex management. And to start with that, like Brenda, you need to have a real good relationship with your provider. And if you're struggling to have that relationship, probably should find another provider or someone who can go step by step with you through the process and find just the right, one size doesn't fit all, like Dr. Ehde said, find the right management strategy for you of a combination of medications and non-medications. So that's my first take-home message. The second one would be to keep a pain diary. To literally do that, you can use phone apps that can help you, and you can take that to every clinic visit and share that with your provider, because you'll forget and you'll get wrapped up in something else and that's important for that moment. And then you need to have that as a reminder, and your pain diary will just record every time, and it will impress your provider with how important this is to you. Then my last thing is with CBD use, make sure that you have products that are certified by the good manufacturing practices, that it's on the label. That will help assure some things, not everything, but it will help assure that you're getting something with very low THC 0.3%. And that is one way of making sure that your money is going to something important. I also kind of wanted to reiterate what Dr. Edie said, is that pay attention to your mood and your environment. So evaluate how these are driving your pain intensity. And these are very important. So actually, that was 4 take-homes. Sorry.
Well, thank you, Dr. Edie and Dr. Maloni, for sharing your expertise in effectively managing MS-related pain. Now, I'd like to continue taking a few more questions that our audience has for you. Steve is asking whether once you have a burning type of pain that's exacerbated by stress, does it ever go away? Dr. Edie, what can you tell us about how stress affects pain in MS, and can reducing stress improve someone's pain?
Yeah, so the answer to that is absolutely. Stress does affect pain. It's by what we call bidirectional. Stress affects pain and pain causes stress. That doesn't mean you have to be in that cycle of stress and pain at all the time. And we know that the areas of the brain that process stress are also areas of the brain involved in pain perception, pain regulation. And so we also know that strategies that decrease stress can have beneficial effects in pain management. So, highly encourage people to recognize when their stress is going up, or how it affects their pain, and to not think it's that. Sometimes what I hear when people hear that stress affects pain, people say, well, does that mean I'm just weak or not managing well, or I just need to buck it up? No, that's not what I'm talking about. Stress is very real and has very real effects on our bodies. And so, please, look at it as something that you can try to take charge of. And if you just are finding yourself still overwhelmed, seek help with that.
Well, thank you. Mel wants to know if MS can cause pain even when you're not having an active flare-up. Dr. Maloni, is MS pain associated with flare-ups or relapses, or can it happen even when someone isn't having a relapse?
Sure. I mean, new onset pain or pain that returns can signal that this is an MS flare or a relapse, and that should be paid attention to. So that might be new onset pain, or pain that you haven't had for a long time and suddenly it's back. The burning pain in the thighs. But like any MS symptom, pain can be constant. It can be in the background. It can be a nag. It also may jump to the front of your consciousness under certain circumstances, such as increased body temperature, environmental temperature, or increased environmental temperature, stress, or infection. So yes, MS pain can be there and not associated with a relapse. Absolutely. So Mel, I mean, MS can cause pain when you're not having a relapse, and it can be a signal that there is a relapse. So both. I've said both, and I hope that wasn't confusing to you.
It wasn't, and it's awfully good to better understand that. Speaking of doing things better, I'm going to call up my partner in crime, who's lurking in the background there, Julie Feel. Julie, I think you have something. I think you have something to add to the conversation.
I do. Well, Dr. Edie and Dr. Maloni, we've had so many questions, so much good feedback, and so much engagement from our viewers who are watching on social media and able to give one another support. I just wanted to give some themes that we're hearing. A lot of people asking about how pain can change with weather changes. We don't have much time, but I just wanted to acknowledge that we've had so many people asking about that. And I think, Dr. Maloni, I'll ask you to just give us a quick answer to that.
The quick answer is that it's a syndrome called Uthoff syndrome, where frankly, the conduction on the nerve is not as facile or as fast as it should be when you have hot weather. So you go out and you run, or you play tennis, or you even just go out in the heat for a picnic, and you feel drained. You're lying on a beach. Yes, that is impaired conduction on the nerve. Less excitatory ions are doing that conduction because of the heat. When you get back and cool yourself off, it all goes back to normal.
Well, thank you. We also got a great question from Christine, And it's talking about adherence or sticking with treatments. And we all know it's probably a lot easier to stick with taking a pill each day than it is for some of these non-pharmacological interventions. And so Dr. Ehde, we probably don't have a lot of time for you to address this, but she's just trying to gather some support or suggestions with sticking with things like daily meditation to manage pain.
Yeah, that's something that all of us struggle with, right? It's the very few people who can actually really successfully work these in every single day of their life. But nonetheless, it's super important. I often recommend people look to, what's the best time of day where you have the most control over your time? For many of us, it's mornings. So although not everybody feels all that great when they wake up, some do, some don't. But maybe carving out time every day and starting small. Rather than committing to maybe doing, an hour exercise, an hour of relaxation, an hour of mindfulness, etc. Maybe just commit to one small goal initially, maybe just a 15 or 20 minute time for yourself to do something that's helpful for you and your pain. And work it in, schedule it in, just like anything else that you're committed to. And also keep the mindset that what you do for yourself is going to have benefits for other areas of your life. So by taking time for yourself and giving yourself permission to do these things, you will be better able to take care of others or whatever other roles that you have if you're first kind of putting the fuel in your own fuel tank.
That's great. Well, before I turn it over to John, I'll just end with a comment we heard from Leslie, and I'm sure others are feeling the same way. She says she just feels so validated to see so many who are also struggling with pain, especially pain that's hard to describe to their providers. So I thank you both so much for our participants feeling validated and getting some great useful information today. I'll turn it back over to John. Thank you.
Thank you.
Julie. Thanks to all of you who submitted your questions and comments, and thank you, Dr. Ehde and Dr. Maloni, for being with us today. I think that one of the best things that anyone can do for themselves, especially during these uncertain times, is to make sure that the information they're getting is credible and reliable. So we'd like to share some resources with you, and these are resources that you can count on to be current and credible. I want to first remind you that if we were unable to get to your question today, the National MS Society's MS Navigator team is your best partner in answering your questions and connecting you to the very best information and resources. It's also worth mentioning that health insurance open enrollment season is upon us, and Medicare open enrollment runs through December 7th. MS Navigators want you to know that they have a lot of great resources and tools for anyone looking at their 2021 health insurance options. There's even a special team that's setting up appointments for Medicare beneficiaries during open enrollment to help ensure that your 2021 coverage is exactly what you need it to be. You can contact an MS Navigator by phone, email, or live chat through the MS Society's website. For more information and resources on managing MS-related pain and living well with MS, please visit the Society's website at nationalmssociety.org/pain. And to learn more about the study Dr. Ehde mentioned that's exploring the use of mindfulness-based cognitive therapy and cognitive behavioral therapy to manage MS pain, please visit uwmsrehabwell.org/adapt. I'd also like to acknowledge that we're in the midst of an emotionally difficult time for so many people, and I want to make sure that you're aware that the National Suicide Prevention Lifeline is available 24 hours a day, 7 days a week. They offer free and confidential support for people in distress, as well as suicide prevention and crisis resources for you or your loved ones. And you can reach them by calling 1-800-273-TALK. Every week on the Real Talk MS podcast, I continue the conversation that we start here. So I hope you'll take a few minutes and give Real Talk MS a listen. You'll find the Real Talk MS podcast at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, Audible, or wherever you find your favorite podcast. With vital funding from supporters like you, the National MS Society will work to ensure that resources and programs like today's are available, and that the MS research community rebounds quickly from COVID-19, so the progress and momentum toward finding a cure continues. As you're able, please make a donation to the Society's COVID-19 Response Fund by texting the word GIVE to 68686, and you'll get a link right to the MS Society's COVID-19 Response Fund webpage. I hope you'll consider contributing today. Remember that you can connect with the National MS Society on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And please make sure that you're on the Society's mailing list so you'll continue to receive the latest information on MS research and updates on upcoming programs like this one. I'd like to thank Dr. Dawn Ehde and Dr. Heidi Maloni for joining us today. And I'd like to thank everyone who's joined us for your great questions. Please remember that a recording of this webcast is going to be available for your review on the Society's website at nationalmssociety.org/MSexpert. Just a quick programming note, we're taking a break for Thanksgiving next week. We'll be back with you on Friday, December 4th. And finally, I have a favor to ask each of you. Getting your feedback on today's webcast is important, so you'll see a survey pop up in a moment when we close out the webcast. And if you're watching on Facebook Live, you'll see a link to that survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us to continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take that minute to fill it out. On behalf of Dr. Dawn Ehde, Dr. Heidi Maloni, and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.